Good evening to the fourth webinar of NSI and CNS on super specialty of part of the super specialty course on controversies in vascular surgery, neurosurgery. This week, this month, the theme is vascular tumors and of spinal cord and the column. So we have three speakers speaking on Dr. Satish, who will speak on hemangioma, vertebral hemangiomas, controversies in management. We have Dr. Babu, who will speak on treatment and controversies in management of spinal cavernomas. And we have Dr. Rajkumar Deshpande, and he'll be speaking on the controversies in management of spinal dural vascular malformations. Before we start off the lecture, I'll request Dr. Clemens and to speak on behalf of CNS. The motto of conducting this collaboration webinars, and followed by Dr. Muthukumar, who is the present Secretary of Neurological Society of India, to speak on the present plans of collaboration with CNS. And I request Dr. VP Singh, who is the future president of the president-elect of NSI, to speak on what are the future plans of collaboration of NSI and CNS. Professor Clemens, who is the chairman of the international liaison between of CNS, I'll request him to please give introductory comments.
Yeah, thank you very much, Mark. I mean, I'm very excited to be here for the fourth time now. This has been a great collaboration, and it's a great series of webinars. And I hope that we will continue in this vein going forward, you know, COVID or not, and we are making steps, and we'll talk about this in a second. But I really want to congratulate you in particular for like pulling all this together so far. This has been really exciting and a really good exchange of ideas. Like I said, I'm very happy to be here, learning from you guys, and really bringing our perspective to the table. And with that, without further ado, I'll pass it on to Dr. Muthukumar. Thank you very much.
Good evening to our colleagues in India, and good morning to all our friends in US. I became a member of CNS way back in 1994, and NSI, our organization, has a long and fruitful association with CNS for the past several years. We had signed an MOU somewhere in the year 2014, which was renewed in 2017. And since last year, NSI has become a strategic partner of CNS. To further our friendship and collaboration, we have started interacting in the super specialty CME. For those who are not aware of the concept of super specialty CME, it's my duty to tell you that this was conceived. This is practically the brainchild of my immediate predecessor and the present president-elect and co-panelist, Dr. VP Singh. The idea of the super specialty CME was to encourage young neurosurgeons to subspecialize, because it's no longer sufficient to be a jack of all trades. And that's the purpose of this. And unfortunately, because of the pandemic, we were not able to hold the physical meeting. As we all of us know, every difficulty provides us an opportunity. And we, to a pleasant surprise, we found, instead of having a one-day webinar or one-day CME, now we have 4 webinars spread over 4 months with good participation with our colleagues from CNS. And I should thank Dr. Clemens and all the other members of CNS for their enthusiastic participation in this super specialty CME. And with those few words, let me hand over to my colleague and president-elect of NSI, Dr. VP Singh.
Hi, everybody. It's wonderful to be here. And this concept of super specialty CME really came because we wanted to be more inclusive for all our members. You know, there was a need, there was a sort of undercurrent of feelings that, you know, all the senior people are hogging on the limelight all the time. And that's the time when we thought we should give credence to our junior members, give them the opportunity and see what they wanted. But although we had a CME which was covering everybody, we felt that we would need to develop the super specialties and get people interested, because there are several centers in our country where all the super specialties are not available. So we thought that all our junior colleagues, after passing their exams at least, should have some exposure to the specialities which they did not have enough exposure to. And with this, we designed a 2.5-day program. We would take them to an isolated space, a scenic space, but where they could not run away and go out sightseeing. But we would have them in a hotel, in a good resort, and then for 2.5 days, we would brainstorm them on a particular specialty. And we thank our colleagues in the pharma industry who supported us, this endeavor. And this became hugely popular. We would have roughly about 80 people packed for 2.5 days, mainly local faculty and one international faculty. And this was the opportunity where the seniors were not there and the juniors could ask whatever questions they want without any hesitation. So this became very successful, and Manas has taken it forward as the chairman of the Board of Education. This year, there was a special challenge because we could not physically meet, but I think we more than made up for it with these excellent set of 4 webinars. Our collaboration with CNS has been very strong. We started off nearly 6-7 years ago, and we had a first joint meeting in New Orleans. And then from there, we found the collaboration to be mutually beneficial on both sides, and it has grown by leaps and bounds. And we thank CNS for being a partner with us in this super specialty course. And thanks, Clemens, for all your support and the active help that you've done. We do hope our friendship is going to continue. It's certainly going to increase. And we made build bridges across the continents. And we do learn from each other. And it's a pleasure to have you with us. Thank you.
Yeah, thank you all for the futuristic comments. And then we'll start off with the webinar. We have Dr. Satish, who is the director of the spine surgery at Sakra Hospital, Bangalore, and he has 24 years of experience, I think, of neurosurgery after completing his residency, and he did his training at Bangalore NIMHANS, and then he worked at Wayne State University, Detroit, with Dr. Rangachari and Dr. Paul, and then he has been working on spine since for the past 20 years, and in addition to he does also some brain. And I request Dr. Satish to speak on controversies in management of vertebral hemangiomas. Satish, can I please share your screen?
Can you see? Thank you, Manas. Thank you for the introduction. Good evening, everyone. The topic chosen for me is controversies in the treatment of vertebral hemangioma. So the objective is very clear here. What are the controversies? And is there any recommendation available for the treatment of vertebral hemangioma? Let us look into that. The hemangiomas, as all of you know, is a vascular malformation within the bony component of the vertebrae. And luckily, its incidence is about 10 to 12%, but symptomatically, symptomatic presentation is less than 1%. And in that, less than 1% of it is aggressive. And most of the symptomatic vertebral hemangiomas, out of which 55% present only with the pain alone, and another 45% of the pain with neurological symptoms. So the Anakin classification, all of you must be knowing, is the standard classification which is given to any of the benign tumors of the vertebrae. And Anakin classification also mentions about the 3 types, that is the latent variety, active variety, and aggressive variety. And all these 3 things can happen with a hemangioma. However, there is significant controversy whether we can use the same classification for the vertebral hemangioma, because especially with the surgical recommendations which are given from the Anakin classification, like marginal excisions or a wide excision, including the adjacent structures, which are not required in vertebral hemangiomas, because very rarely this will turn ever into malignancy. So that is the first controversy. So considering that variety of classifications have been described, one such classification is by Klimov et al., who has done significant work on the vertebral hemangioma, but this is not practically possible and not been elucidated in the peer review. And as of now, it is a classification which can be utilized from the scoring perspective for learning purpose, but still not widely utilized. Considering the management options, variety of management options have been provided for the vertebral hemangioma. So like vertebroplasty or a simple direct radiation, and the patients coming with alcohol injections, and the embolization techniques, or is it the fusion technique with stabilization in this patient along with the decompression? There are many ways which are available, and which way to take and where to go is a significant controversy. Let us look into one by one about the treatment of the vertebral artery, vertebral hemangioma and its evolution. So decompression surgery way back in 1920 itself has been described in every literature in the world. Radiation therapy was being utilized way back in 1930s. And in 1987, the significant work has been done on vertebroplasty as one of the simple and the best method for the treatment of vertebral hemangioma treatment, especially for the symptomatic variety. And in 1994, ethanol injection came into the picture because we were using ethanol into a variety of the neurosurgical procedure, and it was tried even in vertebral hemangioma. And by late 1990s, the intervention procedures took over from the cranial to the spinal area. The embolization technique were described in 1998, and by 2009, when after our significant experience with the gamma knife and the cyber knife treatment for the cranial surgeries, stereotactic surgery has been applied into vertebral hemangiomas. And which one is the best among all these things is still a controversy. And the treatment of this, whether a surgeon sees these patients in the periphery, in the remote part of any country, or in the major setup, which is a tertiary care center or level 3 centers, the treatment varies from person to person. But if the patient comes to you in the periphery with a neurological symptom, the treatment is different from where patients arrives in the tertiary care centers. Let us look into one by one. That's why it's the controversy. So there are numerous controversies. The usual controversies are, what is the best method of treatment of vertebral hemangioma? Is the PMMA versus ethanol injection of shrinking the tumor, which one is the best? And can radiotherapy can be used as a sole treatment? Are the controversies. From the surgical point of view, is decompression should be done before or after the injection of the cement or ethanol injection? When to fuse in these patients, if at all required? Is it an open method or minimally invasive method is required? Is there a radical excision like a spondylectomy has to be done in every patient? These are the controversies which we are going to look in today's presentation. So what exactly is the aim of treating any vertebral hemangioma? Especially in only 1% of the symptomatic patient, there should be some aim as a surgeon we should be having in these patients. So first one is whenever there is an epidural component, which is having a compression either on the cord or on the nerve root, the first thing every surgeon thinks is how to shrink this epidural component so that the canal becomes wider and the pressure on the neural structure go away. Then by doing this shrinking procedure, are we creating any instability? And if so, how to stabilize these patients? And when we are doing both these things, shrinking and stabilization, are we avoiding the complication and at the same time going to prevent the recurrence? And with all these things, at the same time, there should be a significant success in these patients with the least neurological deficit which patients will have, and most of these patients should get back to their normalcy is the goal of treatment of vertebral hemangioma. So let us look into one by one with these 5 goals. Looking at the vertebroplasty, how exactly it works? It works first as a shrinkage of the tumor, because it's very well known that when we inject the cement, and with its exothermic, one, it occupies the space. Second, with its exothermic action, it shrinks even the amount of the tumor which has come into the epidural space, where it has not been filled with the cement, it still shrinks the tumor. And in addition, it takes, gives the great mechanical support to already collapsing vertebrae, and also takes away the local pain by ablative technique. And symptomatic extravasations, is known, but it's very, very less than 1%, especially symptomatic one. And whenever we are doing this kind of the procedure, case selection, proper technique, especially use of the high viscosity cement, significantly reduce the complication to less than 5%. So in this way, the 5 points which I was talking about, does it produce the shrinkage? Yes, excellently it shrinks. It does give the stabilization. It is less complicated, and it definitely reduces the recurrence, but not in every case where you cannot, if there is a slightly tumor coming laterally from the pedicle area where you cannot significantly put the cement, it might have a recurrence, but the success rate is quite significant in these patients. So in conclusion from the vertebroplasty is it can be used as isolated procedure, a standard care in locally symptomatic vertebral hemangioma without a neural symptom can be done. And adjuvant procedure of vertebral hemangioma with neural symptom along with the decompression surgery for the tumor shrinkage as well as local pain relief can be done with this vertebroplasty. There are significant literature available in the peer-reviewed journals. The Klibanov, the classification which I mentioned earlier, he's the one who has done with the highest level of studies. And overall, if you look at these 5 studies which I've quoted here, among the highest number of cases which they have it, there is PMMA is safe and effective in local pain relief. It does give the stabilization with a low tumor recurrence, and it is safe and effective in aggressive vertebral hemangioma, even with epidural extension. So looking at the surgical management, it has become standard of the care in aggressive vertebral hemangioma with a neurological deficit, in the recent modalities to reduce intraoperative blood loss. So there are 3 things which we always take from the surgical point of view. One is decompressive surgery alone, decompression with a laminectomy and fusion, and spondylectomy with fusion. Let us look into these things with the 5 points which I was talking, which including the en-bloc spondylectomy and sometime intralesional spondylectomy with a debulking. So if you look at the decompressive laminectomy, most commonly performed surgical procedure in aggressive vertebral hemangioma with deficit, especially in the peripheral centers where there is no facility available for biplane imaging, where the surgeon may not be very confident in putting either the cementing technique or alcohol therapy, where radiation may not be available. If the patient comes with rapidly progressive neurological deficit, decompressive surgery is very, very common. Is there a literature to say that whether this can be a sole procedure? It is a useful procedure in the primary care center, and vertebroplasty in these patients helps. But the problem with this is it cannot shrink the tumor. It cannot give the stabilization. Rather, we might destabilize the spine, but less complicated, which is universally it can be utilized. It reduces the recurrence, no, but immediate neurological compromise can be taken away with these patients. So there is, there are some articles which, if you see things which are articles before 2006, there are significant articles available, where they have done only laminectomy with reasonable success. But many of them, had a recurrence and destabilization. That's why it's given up. But in the periphery, it can be still useful. So here is a case of one of our patients. A patient who came, a primary gravida, came to us at 36 weeks of pregnancy. She came with a severe mid-back pain with rapidly progressing flaccid paresis of 3 days duration. And in this case, what did we do? First, we had a discussion with the neuro and obstetric team, and the family was counseled. And luckily, we did, our team for obstetrician helped us to do the cesarean section. Immediately on the same day, we did under the same GA, when she underwent a cesarean, we did an angiography and embolization. And on the day 2, we did D9 laminectomy and vertebroplasty. And the embolization, we did in such a way that only one radical artery was supplying it, and we could do PVC particles were injected, and we reduced the significant amount of the hemangioma, and we went ahead and did bipedicular cementing injection. And luckily, this patient, now this is just about less than a year. You can see even the child is walking and the patient is also walking, and it gives the great stability to this patient. At the same time, she's completely relieved of her flaccid paraparesis. So let us look into when to do fusion in these patients. The role of the fusion comes whenever there is a junctional vertebrae involved. If there is a pathological fracture or hemangioma in old age, in addition to the osteoporosis in the adjacent level, in addition to osteoporosis in the same level, if there is a vertebral hemangioma, you can utilize it. And whenever there is a ethanol embolization, there is a risk of pathological fracture, which has to be taken into consideration. So the fusion gives the greatest thing is it may not give the shrinkage, but gives the stabilization, less complicated. It reduces to certain extent recurrence, but not completely. Success rate is significant. Here is one such patient with a D11 vertebral involvement with a significant epidural extension of the tumor. And in this patient, once again, we did an angiography. But you can clearly see in this patient, to our luck, we could find out it was supplying the Adam-Cubic artery, the same radicular artery, and we were unable to do any embolization. This is a very, very important from take-home message, because each radicular arteries on both these sides should be looked into. Whenever we put a catheter, super selective catheterization has to be done. And whenever the loop of vessel, which is seen, which is in the center of the spinal canal, which is nothing but Adam-Cubic artery, at that time, you're not supposed to embolize these patients. And this patient, we did the decompression and stabilization because of the junctional level, and patient is back on her feet after her paraparesis. So the intralesional spondylectomy versus the total embolectomy. So both gives a good relief in these patients, and most of these patients, and especially when you use the adjuvant radiotherapy, intralesional spondylectomy gives same result as the patients with the en-bloc spondylectomy. Whenever we are doing the en-bloc spondylectomy for the vertebral hemangioma, three things are necessary. One is expertise of the team. Second, surgeon's confidence. Fourth, he should be doing the same procedure to other procedures, which like cardomas or a metastasis. And in addition, it requires the allograft, implants, and the fusion rates has to be perfect in his hand. So everywhere we cannot do the total embolectomy in every institution. It requires the significant learning curve, and hence, comparing to the intralesional spondylectomy, the results are almost same. So both of them give, good thing is it causes a shrinkage of the tumor, reduces the recurrence and success rate, and main thing is with the intralesional spondylectomy, less complicated compared to total en-bloc spondylectomy. There are good number of papers which are available. The Goldstein has done a multi-centered cohort study where he has shown the en-bloc spondylectomy versus the posterior decompression surgeries, where they have done 11% of it is en-bloc spondylectomy and 70% were done with the posterior decompression alone. And what is their conclusion is intralesional resection plus radiotherapy has a good local control. En-bloc resection not needed even in Anakin S3 is the conclusion. So if you look at all these things, whenever you add the adjuvant treatment like embolization and radiotherapy, intralesional removal of the tumor and additional therapy gives same result as en-bloc spondylectomy. So in conclusion, intralesional debulking plus RT is as good as total en-bloc spondylectomy. Coming to ethanol injection, the mechanism is devascularization, shrinkage of the tissue, and healing by sclerosis. So what does it do? It definitely releases the shrinkage. Stability doesn't give. This is the main thing problem with the ethanol. Rather, it produces pathological fracture, very well known. And it is, plus or minus complicated because sometimes the alcohol, you cannot visualize where it is going. because it's completely liquefied. Sometimes it goes and creates significant changes in the parasympathetic and sympathetic plexus, which is around the vertebrae, especially the celiac components and the epigastric components. And it can even migrate up, causing the local and systemic autoimmune reaction. And it doesn't reduce recurrence, and success rates need to be looked in, but it always needs a fusion in these patients. So the risk has to be weighed against the benefit whenever you are doing the ethanol injection. So if you look at the literature, the single most article which is coming from India, our colleague Sharat Chandra has done 33 cases, but in every case he has added short fusion into that, and also has mentioned one patient had a transient paraparesis. And if you look at the other authors, all developed the transient hypotension and bradycardia, and the safety of which, unless the anesthetic team and the surgeon is confident, sometimes the alcohol injection can create more problem. And it is also well known that whenever you inject more than 15 ml of the alcohol into the vertebrae, it causes more problem than less than that. And if you had to always, in one vertebrae, you cannot give more than 15 ml. So radiotherapy alone, it is whether it can be given as a treatment. But the problem with the radiotherapy is it requires several weeks to take out the epidural tissue shrinkage. So you cannot wait whenever there's acute deficit, and deficit might become irreversible when we use only radiation as a treatment. And also the problem with the radiation is it may not, unless the whole target area is very well covered, and if you're done as an acute phase, we may not have a complete shrinkage, but it will also can cause destabilization, and isolated, it should not be done. Post-surgery, it can be used as a single therapy. There are different methods are used. In the past, the cobalt treatment were given. In the present, we have SRS as well as the cyber knife and the gamma knife therapies that are utilized in multiple centers. It is a good option for the mild deficit patients when they're coming only with a radiculopathy without a significant collapse of the thing. And it is definitely a good therapy for preventing the post-op relapse of these patients. And it gives very good relief of the pain if there is a radicular artery. And it is a good adjuvant treatment than a solo therapy. So, in acute phase, better not to be utilized. Coming to role of the stereotactic Rt, as I mentioned, the radiosurgery, the problem is the same. It is the stabilization is a problem, but whether it can be used as a sole therapy in acute neurological involvement is a problem. And also the problem with previous cobalt therapy and SRS therapies, there is significant amount of myelitis happens in these patients. And radiosurgery, when the present literature, if you look in, the number of cases studies are very, very less in the literature, and it definitely requires a randomized prospective controlled studies of the multicentric, because in a single center, you may not be having a significant number of cases. And CNS and the NSI combined together, I think in the future, we can look in how these radiosurgery will be effective in the vertebral hemangioma. And as of now, it is considered for the adjuvant treatment, but not as a mainstay. So here is one such patient. This is the patient, 41-year-old patient of ours, who had a thoracic myelopathy in the 2011 and underwent decompression and laminectomy in outside hospital. He came to us last year, 2016. He had a severe back pain, and at that time, they had a fusion surgery he underwent. And in 2017, once again, he came back with a paraparesis with a bladder involvement, where we had to do a revision of the fusion therapy followed by the radiation. Radiation. With this radiation, the whole of the epidural component shrank. And as of now, he is doing reasonably good with residual paraparesis, but he's able to manage his day-to-day activities. So the transarterial embolization as a single solo therapy is almost going away, but it is not efficient in cases with a deficit, and it always needs a radiation therapy in addition to that, or you can utilize that for, as our case suggested, you can use it for the vertebroplasty as well as fusion therapy. And the aggressive vertebral hemangioma, preoperative transarterial embolization whenever feasible, and if you especially the aggressive variety where you see the vessels within the epidural space, and if there is an edema within the cord, that shows that it's highly aggressive with the multiple radicular arteries. In these cases, embolization can be tried as a preoperative method before doing either the en bloc spondylectomy or any of the embolizing technique using the PMMA or alcohol therapy. So in conclusion, if you look at that, the posterior decompression alone, will not give the full benefit to the patients, though it is less complicated. And the best treatment available is a posterior decompression with PMMA, with the fusion, which will take care of all 5 components. That is shrinkage of the tumor, stabilization, it can be taken care, less complicated, reduces the recurrence, and the success rate is very high. Whereas a spondylectomy, you can have the same thing, but unfortunately, it requires the learning curve, and it can be done in a tertiary centers where a spine is, tumors or other spine tumors are also considered. And ethanol injection, whenever you're doing, because of the pathological fracture, it always needs a fusion. And radiotherapy should be used as an adjuvant therapy. So the treatment recommendation is the posterior decompression alone. Only it should be done in a peripheral centers in an emergency case. Spondylectomy, morbid and limited indications, but definitely it is one of the methods. Posterior decompression with the PMMA is the best, ideologically suited for every cases you can utilize. Radiotherapy for the local pain you can utilize, or a radiculopathy alone, but a good adjuvant post-surgery. Alcohol injection needs extreme precaution whenever you're doing, but definitely it shrinks, but needs a posterior fusion. And embolization is not useful as isolated treatment, needs expertise, and also you should avoid the recurrent arteries, especially Adamkiewicz, whenever you're looking into that. Thank you once again. Thank you.
Thank you, Dr. Satish, for giving an excellent lecture on management of hemangioma and giving a guidelines that which is the best way to treat. I know Dr. Muthukumar and Dr. BP Singh will have questions, but we'll have the questions before the case discussion. So we'll finish off all the 3 lectures.
Sure.
I request Dr. Clemens to invite and introduce Dr. Babu.
Yeah, thank you very much. And this was a great overview of some of the more common and vexing problems that affect the bony component of the spinal cord. We're going to take a little bit of a change in tack or direction here and go to the intrinsic problems of the spinal cord. And it is my great pleasure and privilege to introduce Dr. Babu Welch, a good friend of mine, who is a professor of neurosurgery and radiology in the UT Southwestern in Dallas. I'm looking forward to his lecture, given his long experience with treating these problems, and coming from the perspective also of being a dual trained endovascular and open neurosurgeon. I'm sure there's some components that he will tell us about. So without further ado, thank you very much for being here, Babu, and I'm looking forward to hearing what you have to say. You're still on mute.
Thanks, Clemens, and good to see everybody again. This has been a good lecture series, I think, for everyone. So, and we're taking advantage of the technology. So let me make sure we're seeing the slides here. So, yeah, interestingly, as a dual trained neurosurgeon, I think we got the one pathology where there's not a lot of endovascular involvement. I'd be interested to see what our next colleague is going to talk about from the standpoint of spinal fistulae. A lot more dual overlap there. But cavernomas of the spinal cord are where I'm going to kind of talk about, and we're always kind of taught to put our disclosures up here, so just breeze through that. But most of this is related to the endovascular side of my world. The cavernomas in the spinal cord obviously are a little bit more of a rare lesion in general, and we will talk about them in terms of some of the epidemiology, natural history, and then really more of the surgical adjuncts, and obviously controversies is the topic. There, in terms of vascular abnormalities, not as rare as we think. 5 to 12% is what I can typically see in the literature. But interestingly, if you have a spinal cavernoma, about a quarter of the patients at most will also have a brain cavernoma. So this is a time where surveillance imaging would be necessary. The cavernomas of the spine aren't as insidious as the fistulae. Usually, if there's a progressive myelopathy, in my experience, we'll usually see cavernomas and diagnose them a little bit sooner to the initial onset than we will with the fistulae. But the pathology is similar in that microhemorrhages and gliosis scarring as a result of those microhemorrhages can have a lot to do with the way the patients present. Literature will tell you a sensory motor deficit is more commonly referred to. I kind of don't like that. It's either a sensory or a motor deficit, but I think we sometimes get rid of we don't pay as much attention to some of the pain that's a long-term result. And some of the patients that we've had excellent surgeries in still have some neuropathic pain that we're still treating long-term. There is a component of the cavernomas that will present with acute hemorrhages. And that's, again, literature-wise, somewhere between 1% and 5% of the patients will present that way. And that's a little bit different than that insidious onset. And there is a little bit high, once you hemorrhage once, then your chances go up pretty high for having additional hemorrhagic events. The take home really from the epidemiology is most patients, as they present in that 30 to 40 year range, which is the more common one, once you start, you're probably going to continue to have some sort of symptomatology over the rest of your lifetime. There's some discrepancies in the literature in my last review that really talk about male versus female. Some series, which are very small, most of the series, largest series I've been able to look at was 53 patients, but most of them are 1 here, 2 there, 10 there, very similar to the hemangiomas. But whether or not it's a female preponderance or a female to male equal, I think can be debated. I just briefly mentioning the familial cavernomas, and we have a few clusters that we follow here at UT Southwestern. The cases, there's a little bit higher possibility of multiple spinal cavernomas in patients who have familial disease. 10 to 30% is what the literature will tell you. It's a similar, there's really no difference in the chromosomal abnormalities at 3 or 7q. But the hemorrhagic presentation is probably a little bit more common in those with familial cavernomas. And I don't think the series are large enough to say that's because they have multiple or not, but you can draw the parallel. So the imaging is important, and I'll get into the presentation how that relates, but it's not much different than what we're used to seeing in terms of a cavernoma, the typical popcorn lesion with heterogeneous signal on T1 and T2 suggesting hemorrhage, usually with the hemosiderin ring. We'll see that a majority of these spinal cavernomas are intramedullary, but there are varying case reports of intramedullary, extramedullary, intradural. Some are actually, pushing in or have gotten into the dura. Those are very rare, but the majority of them are intramedullary. The acute presentation affects the imaging somewhat. And these are a couple of images of patients that I've had over the years where you can see this is the same cavernoma at different times. So the presentation, the hemorrhage, and then the edema that's associated with the hemorrhage does make it a little bit difficult to pinpoint this is a cavernoma. But if you follow them over time, they tend to settle into the more heterogeneous lesions. Some lesions that can be mistaken for cavernomas, I think, are important to mention. And of those, the more common hemangioblastoma, spinal metastases, again, the edema associated with an acute presentation of a cavernoma, or is this a met? Obviously, the staging of the patient is important here. Gliomas, again, with the hemosiderin. But again, outside of the familial cases, the multiple spinal cavernomas are pretty uncommon. So, cranial axis imaging, unless the symptoms don't fit, is not typically my routine. When we talk about the indications and timing, I think this is probably where we can, if we're going to create a controversy for these lesions, we can probably create it here. The progressive neurological deterioration is, anxiety producing in many patients, especially those, who have lesions that are less accessible. So that progressive neurological deterioration is definitely a lean towards the surgical discussion. Multiple hemorrhages over time, you know, the literature and my own patients that I've cared for, they typically come in clusters. We've all seen cavernomas in the brain that do the same thing. They'll, you know, hemorrhage, and then they'll have a period of time where they'll relax a bit. But I think the evidence of multiple hemorrhages over time, which may overlap with that progressive neurologic deterioration, would also lean you towards surgery. A lot of discussion is held in those patients who have acute bleeding with mass effect. If there's a hematoma that's really, you know, causing deterioration, obviously that's a little bit more lean towards. But really, the controversies and the treatment of spinal cavernomas really comes to where do they need to be to treat them, and then when. You know, I borrowed this from a friend, just kind of giving you an idea of the various approaches to, and you know, we put this in the same basket as tumors of the spinal cord, but you know, approaching through a midline myelotomy in the posterior median sulcus, closer to, as you can see in this magnified view, the posterior lateral sulcus, if it's, you know, lateral one way or the other. Obviously, the exophytic lesions are the ones we like to see. That doesn't give you a whole lot of discussion about where to go in. That becomes more of a when discussion. The lateral ones that don't, that are a little bit more difficult to discuss, are the ones that don't present to the PIA, that are lateral, not necessarily in a preferred sulcus. And rarely do we have, and are we talking about the more anterior, which is not included on this diagram, but those that are more anterior, a lot more difficult to get to. Typically the Peel presentation, you're also putting the anterior spinal artery and the vasculature at risk. So, you know, the where and when to do any kind of procedure for a cavernoma is where we'll discuss a little bit. So, you know, I put controversy here in question mark because it is a little bit difficult to create one, but you know, the location of the lesion, is it fair to say that location of the lesion and the symptoms of presentation will dictate the course of management? I think most of us are there. As I showed in the prior slide, you know, a Peel presentation, this gets into our second, you know, controversy, you know, an asymptomatic lesion, which is exophytic. Should that just be excised because it's exophytic and we know that that younger patient is going to progress? How did they present? Do they have multiple cavernomas in the brain and we just happen to screen them? Symptomatic lesions that are exophytic, I think, are much less controversial. And a lot of the times we're waiting for this next bullet, which is the deeper asymptomatic lesion, to actually hemorrhage, to produce it, so, you know, to provide a little bit more of a decent surgical corridor. But is it controversial to say that these deeper asymptomatic lesions should be watched? I don't think so. But what is the radiological follow-up, and how should we dictate that? Especially as I know in the U.S. we're scaling back on a lot of imaging and things like that. How do you really follow these patients, and how do you educate them about, you know, when to speak with you in the clinic? So when we talk about those patients that are surgical considerations, you know, what they're typically an exophytic, multiple hemorrhage, progressive neurologic decline, you know, first thing is really the acute presentation. Is the acute presentation of the patient the time to go and treat the patient? Or typically, are we going to wait our 2 to 4 to even 6 weeks before to allow for some of the initial deficit and edema to resolve before a surgical trauma is performed? So evaluating the surgical corridor is very important. We talked about that in that prior diagram. The midline lesions are much more accessible, but that posterior median sulcus is also very important as you go along the nerve root, and I'll show some examples of that. The width of resection is really just needs to be as deep as enough to allow for the depth of the approach, but also taking into account a lateral approach. So the more laterally that you need to be, you may get into the facet. This may be a multi-level, you know, facet violation, and therefore stability of concern that should be entertained as we go towards these lesions. And I'll comment a little bit on the surgical adjuncts. You know, classic surgery for cavernomas is, you know, sharp dissection, bipolar as needed to allow for any kind of working around hemosiderin locations. But I found the CO2 laser to be helpful on occasion. I've personally never dealt with ultrasonic aspiration, but larger lesions It is reported in the literature, but typically in my practice, the CO2 laser is one piece in addition to the microscopic microdissection. And then intraoperative monitoring is very important, as we all know, to monitor the progress. A partially resected cavernoma is not a treated cavernoma, and most of the literature will show us that the patients who do well do well with a complete resection. So that really is the goal, but how that's tailored by the intraoperative monitoring is important. Just a brief nod towards intraoperative monitoring and this trends. I think it's very common that the somatosensory evoked potentials and motor evoked potentials are monitored. That's standard. There's a lot of talk about epidural monitoring using D-wave, and the D-wave itself is a adjunct to the MEP. So the motor evoked potentials that we usually talk about are transcranial, multi-pulse technique, have the patient stable, send a couple of signals, make sure we've got the motor evokes aren't changing. But there's a decent amount of literature, out now talking about D-wave abnormalities, and to allow for give us a better idea about those patients who typically will wake up weaker or with a new deficit. Will they recover based on what we've done? That D-wave is monitored with epidural electrodes above and below the lesion. And then it's a single pulse reading. This is an example of the readings from this article by Costa et al. That really looks at that asterisk where this is an example of a patient who had a smaller D-wave, did lose motor evoked potentials, but had an improvement in the D-wave post, and a patients like this actually get better a lot faster. One comment on that is just, now you have epidural electrodes that you're putting in. Is it worth the change in exposure to get this? I think a lot of it would depend on how the patient presents, and we'll talk about the patient presentation and how much it affects the outcomes. So a couple of just examples here, just talking, and I'll kind of walk through. As you'll see, I've sped some of the video up. But on this first case, this is a gentleman who's a 56-year-old male. It's a patient of mine. I've treated his son, both of his sons, with cranial cavernomas. And he had surgery for cranial cavernomas at another institution. And once we treated his sons, he advised me of this spinal cavernoma. This is at the T9 level. And from his son's treatment to not too long ago, he had 3 hemorrhages, most over the summer, that produced more of a lateral exophytic component to the cavernoma. And as a result of his 3 hemorrhages, which produced some right lower extremity sensation loss and dorsiflexion loss, he did have some thoracic level that fluctuated, but in general, he tended to recover after each hemorrhage to his baseline. We discussed going to surgery with him. Sorry. So working through this one, as you can see that exophytic, he had a T9 lesion. So what we did was a T8 to 10 laminectomy. You can see here, it's just immobilizing the dorsal vein. A lot of discussion here. You can very clearly see the blue presentation of the cavernoma. But we know from the imaging that there was a more leftward approach to this. The camera is upside down. I'm left-handed, so just so you can see, this is the left side, that's the right side. As we move forward, you see we're just opening the arachnoid here, we're mobilizing the dorsal vein. Because the more we move that vein, the more that I can really see some hemosiderin and also this thinning, where a better surgical corridor, I think, could be achieved. A couple of technical points here. The use of cotton, you'll see a couple of pieces here. We use cotton wisps. This is a round knife that I like to use that we got from our ophthalmology colleagues. And as we dissect here, what you start to see is not only did you see this kind of blue component here, but there's this exophytic component, which really that's when you say, okay, that's where we want to be, okay? Because we know we're now seeing this lesion where it's presented itself, that things are a lot more thin here, and you can see more evidence of the gliosis surrounding hemosiderin there also. So that was, mobilized a couple of the small arteries here in addition to the dorsal vein. and we're consistently moving leftward. Not a lot of need for any violation of the facets, but expanding the lateral exposure through both sharp and just kind of some, microforcep exposure. Now we tend to use the hemosiderin to work into the lesion. You can see there's hemosiderin around it. The bipolar I usually have set at about 8 watts. I don't use much more than that. I go in saying I'm going to do most of my bipolaring within the lesion, but I don't think that's really as fair. Just keeping it low. We tend to work with a diploscope here, so you can see my fellow and myself with good retraction ability. A lot of conversation about this is where I'm going, this is where you need to produce. Pausing every once in a while to get the motor evoked potentials and know that we are not seeing any changes. In this case specifically, right in this area where we started to resect, we had a slight decrease in the somatosensory evoked potentials that was related to a drop in blood pressure. One of the comments that I think are important is when we're preparing for these lesions, we are potentially creating a spinal cord injury. So keeping these patients with a MAP, usually above 70 to 84 hours, and treating it like a spinal cord injury, that's what I would do. This patient had a slight decrease in that, but as the MAPs came back up, we saw the SSEPs come back. I didn't do D-wave here, and you can just see kind of a tracing here where the motor evokes were very good, a slight decrease in our wave here, but that returned as we got the blood pressure back to where it needed to be. And then resection of the lesion occurred very well here. This is more of an example of, you saw I was more dissecting softly, a little bit of bipolar, but the gliosis from the 3 hemorrhages created a little bit more of a need to actually cut here as opposed to just dissect the way we were doing before. So removing these lesions, I think, is helpful. This is more of the classic method by doing this with bipolar and under the microscope. Just an example of a prior case where we actually, just an example of using the CO2 laser. The CO2 laser itself is helpful in that the bipolars aren't as big, it's not as big as a bipolar. And you can see here, we're just taking the small vasculature and then entering into, you can see the cavernoma there. So not a lot of thermal injury to the other parts of the spinal cord. And it allows you to have more of a dissector, still using your 4th hand there. But that CO2 laser, when you can use it, is helpful. It doesn't help with larger vessels. If you've got larger blebs and things like that, it doesn't do as well because you're challenged with the energy that you have to give to it and the damage to the spinal cord. But having that available, I think, as an option is a good adjunct. When we talk about the surgical, outcomes for patients, this is the best meta-analysis I was able to look at and bring to you. It really came out of the Helsinki and Turku Hospital. They looked at their own series back in 10, but they also looked at most of the series up to that point. There were 383 cases that they reviewed. 62% of the patients improved. 9% of the patients had permanent worsening, and they looked at them almost close to 3 years. Every series you look at, and our personal experience here is that if the patient presents, the outcome is predicted by the presentation. So a prior hemorrhage or severe deficit, they typically won't do it well now as well. If you have a prior hemorrhage and a hematoma cavity that's addressed acutely, that may make a little bit of a difference. The intramedullary location, as I mentioned, is a majority of these. Can be associated, but I would say intramedullary and prior hemorrhage and deficit. And how did the patient progress? Was it a slow progression, over a shorter period of time? Okay, better. A rapid neurological deterioration. Typically, those patients were 70% more likely to have a less outcome with surgery versus those that did not have a rapid neurological deterioration. Most of the time, we'll see that any kind of radicular pain component will improve better than the motor deficits. And there's not, I think, as our prior presenters discussed, these are small lesions, multiple small case series. A majority of them, because they present in the thoracic spinal cord and not as much in the lumbar or the cauda, discussion about bladder function recovery is not as robust in the series as other spinal cord injuries and column difficulties. So when we talk about the cavernomas, I think it's a little bit difficult to create a controversy, but I think monitoring of the patient, not in the surgery, right? But how are we deciding to take these patients to surgery just because they have lesions? The exophytic young patient with an easy access, they're probably going to get worse over time. It's probably worth taking them. I don't think there's much controversy there. The deeper lesions, again, causing a deeper lesion in a patient who's asymptomatic, they need to be educated more about these are the deficits we're looking for, and then serial monitoring over a large number of years using MRI, I think, is appropriate. The favorable, presentation in a young patient with a manageable deficit, we should talk about the discussion, but it really needs to be a good anatomical corridor to actually work through. And then really, these aren't lesions, as I think our prior presenter also mentioned, these aren't lesions that you want to just take care of and then send them someplace else if something happens. Usually surgical monitoring needs to be there, good microscopic technique, a good team. Lasers important to have. I think it's a good adjunct, and it's nice to have in those patients. You saw the difference in the dissection that you get when you're working with a laser versus bipolar incisors. So I think not having these just done in the community centers is also important. So I want to thank everybody for the opportunity to speak with you about these lesions, and I'm looking forward to seeing the discussion about the spinal levi fistulas. Thank you.
Yeah, thank you, Dr. Babu. And we shall have the discussion at the end. And I request now Dr. Rajkumar Deshpande, who is the chairman of Department of Neurosurgery at Fortis Hospital, Bangalore. And he'll be speaking on controversies in management of spinal vascular malformations. Can you please share your screen, Dr. Rajkumar?
I hope it's seen, Manas.
Yes, yes.
Yeah.
Thank you, Dr. Manas, Dr. Singh, Dr. Muthu, and the NSI and the CNS for this opportunity. I think it's a nice thing to discuss about spinal AVMs after the good discussion from Satish and Dr. Babu. So let's discuss and delve into it straight away. These are rare lesions. Just give me a moment, please. Sorry about that. These are rare lesions. These are approximately 5 to 9% of all vascular malformations of the CNS, or about 3 to 4% of intradural spinal lesions. Obviously, compared to the cranial AVMs, the clinical impact is often worse, basically because the size of the spinal cord is much smaller, and spinal cords are generally less tenable as far as the impact is concerned. So you can broadly divide into arterivenous fistulas and arterivenous malformations. We call them AVFs or AVMs. Now, aneurysms are very rare, and most of them come to attention or concomitant to a spinal AVM. And actually, if you see an aneurysm by any chance in a patient who has a MRI, and then you should actually look for an AVM, which is somewhere else. Obviously, majority of the AV fistulas are dural AV fistulas. So this was known for many, many decades and actually came into prominence once MRI became a common investigation tool. Now, in a controversial subject like spinal vascular malformation, if you establish a treatment plan, is a very difficult thing to do because there are not many cases for, in many institutions, the case reportages are very rare. Therefore, we have to learn to do certain things. One is to identify the type, estimate the clinical course, study the vascular anatomy of the lesion, and then weigh the risks and benefits of either endovascular or microsurgical treatment. So let's delve into the classification first, because it's very important to understand what kind of lesion it is. The standard original classification was the type 1 to 4, where the spinal dural arteriovenous fistulas, the DAVFs, were either type 1 or type 4. It's very important to remember. The type 1 or the type 4. The actual AVMs are type 2 or type 3. Type 3 being the metameric or the jonal AVMs, where it involves the tissue, neural tissue, dura, bone, muscle, skin, etc., etc. And we'll show some examples of it as we go by. The ones which are actually within the spinal cord, the intramedullary AVMs or the globus AVMs, are the type 2. Type 1 is a spinal dural AV fistula, which is actually located in a dural sleeve of the spinal root. And you have a single coil vessel which goes to the dorsal pile surface of the spinal cord, which was the most common type of DAVFs that was seen very much earlier. And then you have the perimedullary AVS, which are either in front or the back, typically more in ventrally, and they were classified into subtypes A, B, and C. Then we have the Spitzer classification of 2002, where all the vascular malformations were divided into hemangioblastomas and cavernomas, which I'm not dealing with. The previous speaker, Dr. Babu Welch, did a good job of it and beautifully presented his surgical skill in excising the cavernoma. And I'm also not talking about spinal cord aneurysms, which are very rare. And this talk is mainly concerned about the AVFs and the AVMs. He classified it into the extradural variety, which was not seen in the first AVM classification, spinal AVM classification, and intradural variety, which fell into the ventral or dorsal type, and the arteriovenous malformations, extradural, intradural type 3, which were the Cobb syndrome or the perimedullary type, and the intramedullary type 2, which was in the type 2, and a special conus medullaris type. So it's very different than what the original classification was. And this was in this particular article, which was there in neurosurgery. So basically, we have the following types: the extradural AV fistulas, the intradural dorsal fistulas, intradural ventral fistulas, the extradural intradural AVMs, intramedullary AVMs of two types, as compact and diffuse, and the conus medullary AVMs. So I think we have the 6 varieties, and we have to juggle to see which of the AVMs fall into, or the AVS fall into this pattern, and then discuss what happens to them, what is the natural course, etc. So let's understand some basic relevant anatomy. I think most of us know about the anterior spinal artery, the posterior spinal artery, and the artery of Adamkiewicz, etc., etc. Most important to understand is all these are coming from the radicular branches, and this is seen in this particular view. I hope you're seeing my arrow here. You can see the radicular arteries, you have the dorsal branch, and you can see once the segmental artery goes inside and divides into the spinal branch, you have the anterior and the posterior radicular arteries, which go and supply the surface, what you call the vas or corona, and the anterior spinal artery is augmented by these arteries. And you can see this beautiful picture, which is from the Neurosurgical Atlas. It's a beautiful picture. It gives the relevant anatomy beautifully. And in the conus, we have the anterior spinal artery, which forms an arterial basket, with the posterior spinal artery at the tip of the spinal cord. So then we have to identify the type. So I'll give some relevant examples here. This is an Excel illustration demonstrating an extradural AVF, and this forms the epidural or the extradural type. The Spitzler's is extradural, and in the older, it was not there. It's called the epidural type. Then the radicular artery, which feeds the venous system at the dural type, is the dural AVF type 1 or the dorsal. Here you find the classical on the root, and from the root you have the fistula, and then it goes to the dorsal type. Therefore, that's what I said. Normally what happens is the normal venous flow in the coronal venous plexus is diverted to the dura and to the extradural system. When in the spinal dural AVS, the arterialized blood flow then produce this dilated serpiginous veins in the spinal cord. So this is a high pressure system. It leads to venous congestion, hypertension, ischemia, and myelopathy. So this is a very beautiful picture, shows the microarteriography of a particular patient with this kind of a disease. Then comes the intradural ventral AVF from the anterior spinal artery and the enlarged venous network. Here, there are 3 lesions which are classified. Type A are small and have a single feeder. Type B lesions are intermediate. Type C lesions are giant. These are really multipediculated, have massively dilated venous channels with extraordinary high flows. So this is the type which I said is a perimedullary or the ventral intradural type. So on the right lower corner, you have this particular classification to make it easy. And here in this particular variety, you can see that anterspinal artery is flowing directly into a fistula, and interruption at this level is likely to find a cure. The metameric are the ones which are described as Crop syndrome. You have this arterial, it's a beautiful picture which shows the whole segment of the vertebra, the osseous bone, the dura, the muscle, the whole area is involved in this particular variety, which we call the extradural, intradural. In the intramedullary AVM, we have the compact ones, which is 1 or 2 segments. This is a illustration of the same, whereas the diffuse ones are extensive in multi-level. So these are the multi-level intramedullary types. The conus medullaris AVMs typically exhibit multiple feeders from ASA and PSA and large dilated shunts. And you can see it here at the conus. And this particular conus variety is separate because it has a distinctly different way it presents, and the cure for this are very difficult to achieve. So the natural history is that there is there are no established treatment protocols to say that if you do this, these are likely to be the outcome of that. So basically, very much before, in the 70s and 80s of last century, we had a large series of patients with Aminov who had a fantastic series of vascular malformations that had never hemorrhaged. But I think those are all very distinct subgroups. So the clinical course for these patients generally consists of a progressive neurological decline, and most by the end of 6 months, they'll have some sort of debilitating course. Typically within 3 years, they'll be largely disabled. And if they don't treat, this decline is really terrible to see. The clinical characteristics of AV fistulas in the extradural type, which is here in this particular column, you can see that it's due to a venous congestion and spinal cord compression. Whereas in the ventral intradural type is the similar compression and venous congestion. And whereas the dorsal intradural, you have only the venous congestion and rarely hemorrhage. And most of them present with a progressive myelopathy. And the diagnostic modality obviously is MR imaging, which we'll talk about in a while. And these were different nomenclatures earlier. Now, coming to the natural history of these spinal AVMs, these are congenital lesions, and they are basically high flow and high pressure characteristics results in venous hypertension and hemorrhage. Very often, this is due to a myelomalacia that causes the weakness that happens. Now, hemorrhage is not so common. If it happens, it results in acute onset of either back pain or suboccipital pain, with and without loss of consciousness, with a sudden deterioration of motor function. So how do we investigate these patients? Obviously with MRI, and MRI being the most common, and occasionally with myelography and MRI is not possible, and selective arteriography of the spinal vessels. MRI is obviously the choice. It shows serpiginous vascular flow voids in both T1 and T2 weighted sequences. The T2 weighted sequences show cord edema, myelomalacia, infarction, or hemorrhage. And then hemosiderin deposits possibly indicate remote hemorrhage. And the MRI also tells us which location of the spinal cord is involved, whereas the nidus and there are single or multiple lesions. For example, this particular patient which we had shows, which this was from neurosurgical class, I'm sorry, shows a patient who had this kind of a phlovoid in the T2H sequence, which is seen beautifully at the higher level. And if you do see the arteriogram, you can see this feeder into the AVM straight away there. This is another patient which had a large conus lesion, had a angiogram which shows the AVM. Now, a myelogram is done where MRI is contraindicated. That's because of various reasons. Injection of contrast into subarachnoid space. The myelogram is a very old technique. We had started our neurosurgical training with myelogram. And I think, people who not into the myelographic era will not know much about myelogram. It shows filling defects, serpentine filling defects, and a positive test in myelogram indicates the need for an angiogram. This is the gold standard, selective spinal arteriography. And it's very critical because it shows the type of vascular malformation, the spinal level, the configuration of the fistula and the nidus, and identification of feeding vessels. Now, is there a real controversy in the management? Yes, controversies exist, basically because no center has, on an average, a large number of patients to determine. Few centers have it, and they are the ones who guide us in towards, whether it is towards microsurgery or is it an endovascular treatment. So few centers have reported large series of cases. The preferences vary based on the center. Now, clearly, some indications for microsurgery or catheterization of the arterial feeder is when it is impossible, you prefer microsurgery. You do microsurgery when endovascular management has failed, or when the endovascular management has been done and then recanalization has happened. And when there is a type 1 intradural ventral DVF, where there is a single feeder like I showed in one of the pictures earlier, the endovascular therapy might put the anterior spinal artery at risk, and therefore surgery in such patients is preferable. So for a type 1 AV fistula, I think surgery is preferable because a simple clip ligation or an excision after coagulation of the connection between the artery and the vein will just cure the patient. In patients who have the fistula related to Adam-Kivig's artery, endovascular methods might sometimes put the artery itself under risk. In such patients, surgery may be preferable. And of course, if the fistula is dorsal, surgically it's more amenable than when it by endovascular approach. So let's see some of the series that have been in the literature. This particular series from Mayo Clinic had 92 patients. They had a microsurgical treatment which achieved complete obliteration in 95% of the cases. And this was a type 1 fistula, which is obviously a very good fistula to be approached by surgery. In this Stanford series, they collated patients from many centers, 976 patients, a huge number. They were trying to see what are the outcomes and trends in management. They were trying to see whether the costs were increased. What's important to understand is patients who underwent open surgery had a greater cure rate. However, those patients also had a greater complication rate. That could be because the complexity of spinal AVM pathology in surgical patients might have been far more than in the endovascular variety. So that's another paper. This, of course, is one of the best papers of spinal AVFs and AVMs, neurosurgical focus by specialist group from Barrow. In this particular patients, preoperative embolization was used in 40+% of patients, about 20% in fistulas and 56% in AVM groups. Pure embolization was used only in about 12% of patients. 90 patients presented with a neurological deficit, and about a quarter of percentage, 25% of them showed improvement after surgery. Now, important to realize is they use what is called as a pile resection technique, where you occlude the AVM at the border of the AVM at the surface of the cord, and actually you do not follow the nidus into the spinal cord parenchyma. The aim is to try to obliterate the lesion from the feeders, but not go into the spinal cord. For example, it's better to avoid the dissection into the spinal cord to avoid the damage. Now, what happens is, if you want to follow the nidus into the spinal cord, they say that it is better if you follow the hematoma or a syringe. Otherwise, try to do the pile dissection technique. They have extensive experience and they're beautiful photographs of showing a cervical spinal AVM where they used intraoperative arteriography, ICG, and the flow 800 image, which showed different nidus formations, how this removed the AVM only by using the pile dissection technique. Now, actually, the pile dissection technique was popularized by Spertzler after the first paper that came out from Miyasaka et al., where they performed it in 17 cases with a very good obliteration rate. This group from 2020, this is one of the latest journal neurosurgery spine article, which discusses the microsurgical versus endovascular treatment of epidural AVFs. This I think I discussed. Now let's go to endovascular treatment. The goal is obliteration of the fistula in AVF or nidus in AVM. The important consideration is to understand the artery of Adam Kiewicz, which is between T8 and T12. This is an hairpin bend seen in this cadaveric specimen. Now, the goal of embolization is to penetrate a column of NBCA to the proximal portion of the draining vein and not go to the distal vein. If you go to the distal vein, it's likely that it's the over-penetration. It could cause venous congestion. Therefore, the location of where you actually put the NBCA is very important. Now, the materials used generally are PVAs, microspheres, liquid adhesives, that is like NBCA, onyx, and a variety of coils. Now, extradural arteriovenous fistula can often be treated by endovascular procedure. And this is a transarterial approach, but occasionally a transvenous approach can be used. So this is what is as epidural. This is an example that I could get from the literature. The microcatheter is within the fistula feeder, is right L1 injection, and with NBCA and coils have been put, and the fistula is cured. In the intradural dorsal AV fistula, which typically is beautifully done by a surgery, it can also be done with a endovascular technique. But I think the majority of literature says that it is better done with a surgery. So this particular patient actually is a chance patient that came to our hospital who has been treated for myelitis for many, many months. And then he came with a progressive walking difficulty. He is currently paraplegic. And our radiologist, on reviewing the MRI outside, noticed some few flow voids here, which was thought to be in just artifacts in the previous report. But we went ahead with a spinal angiogram, and it showed definite serpiginous appearance here. And then we treated that patient with a with the microcatheter in place, and we blocked the vessels. And this patient had a marginal improvement in neurological status initially. And then at the end of 1 year, the cord atrophy had actually reduced. So the edema had reduced. There was no enhancement, and the patient had improved significantly. Regarding the ventral arteriovenous fistula, we discussed that there are 3 varieties, A, B, and C. A being the smallest, and C being the largest with multiple fistula. The type A is amenable for either surgery or for an endovascular therapy. There are some examples here. In the extradural, intradural, metameric type fistula are very, very difficult to treat. The clinical objective is to just possibly just be palliative in treatment. Complete obliteration is very rare. I can show one case. So in this particular case, I will show stage embolization. These are from my colleague, Dr. Sharat, who had a patient who came with subarachnoid hemorrhage, had a CT which showed a fourth ventricular bleed, and evaluation showed a malformation. This was a conus lesion, and the patient had an angiography which showed the avia. And also patient had a pelvic avia in the pelvic cavity, as well as in the gluteal region. So this was the spinal avium and a pelvic avium with what we call as a metameric or a Cobb syndrome. And he went ahead and treated it with microinjection and glue. It required a second sitting. And then, the final cast is seen. And the patient actually did very well. These are the pre-op and post-op embolization MRIs. And the patient did really, really well. He had no neurological deficits. I think it has to be observed over time and see what happens. The intramedullary arteriovenous malformations, the classical type 2, are typically treated with endovascular methods. This is the patient with a localized method. And in some patients, surgical resection is for very, very small located, highly localized of this type can be excised. Conus medullaris aviums are a big challenge. Spesler and colleagues have the largest experience. They are treated with surgery and embolization. These are some of the examples. So we monitor during surgery as well as endovascular therapy, SACP and MEP. This was nicely presented by the previous speaker, Dr. Babu, about monitoring, so I won't delve into it too much. It's important to understand you can do some provocative testing, and that can be utilized during surgery as well. Corticosteroids are used for spinal cord aviums. They're not useful in AVFs. And then, of course, in all these patients, we need to do follow-ups. Complications in endovascular therapy include, there's a direct consequence of embolization technique. Is secondary to failure to obliterate the lesion and probably due to decanalization. So infarct can happen. It can be a fundamentally, incomplete treatment. It can be very difficult to treat because they can be extensive. And as I discussed earlier, a distal occlusion of the venous drainage system can result in venous hypertension and consequences because of that. So institutions that favor embolization as treatment of choice say that, it's less invasive. You can do multiple embolizations. You can perform embolization in the first sitting itself, early rehabilitation, and then, of course, if the embolization fails, there is surgery, etc., etc. So both surgery and endovascular therapy appear to be acceptable approaches. Some recent literature supported a move towards endovascular therapy, whereas the surgery is being reserved for refractory cases. So these are articles from Harvard, which basically reviews the 101 extradural AVFs, and they found that 32% ended up with surgery, 68% endovascular, and the rates of embolization, etc., etc. Basically suggesting that there is a move towards endovascular or rather than surgery. Then regarding the type 4 arteriovenous fistulae, these are the kind of type 4C lesions which really require endovascular therapy. And in these particular patients, I think surgery should not be attempted. These are the latest articles that we have seen from August of 2020 from Watanabe's team. Now, they have discussed a microsurgical or endovascular strategy for spinal AVFs. in their particular group, 35 cases, 10 years. They had surgery in 17 cases. They tried to use endovascular surgery as the first choice and whenever it's safe. Microscopic direct surgery was considered for cases in which endovascular access was challenging, and combined surgery in 5 cases. And if you see the results in the flow chart, 80% success in microsurgery, 90% in endovascular, 80%. So basically, they had a very good cure rate in all these cases. And there are a lot of series available. I just put up a series which had more than 50 cases. And I don't know whether this kind of great number of cases are available in many centers. Our own center, we see about 1 to 2 spinal AV fistulas in a year. So it really is not a great number as we look into it. So radiosurgery as a modality of treatment, I just want to cover. In 2006, there is one large series where 24 patients with intramedullary lesions were treated. And then these were followed with annual MRIs. And they say that the follow-up was good. Of 8 patients, 3 displayed complete obliteration. There was no evidence of further hemorrhage, etc., etc. This was by Freiburg, in Freiburg School of Medicine in Chicago. They collated all the group of patients. They conducted a systematic review of English language literature, articles. There were 8 unique studies comprising only 64 patients. So obviously, the number of patients are very small. It's very difficult to say that the kind of therapy that has to be used radiosurgery wise is not recommended as a routine management of spinal fistulas. So the key points of this literature review is that endovascular surgery should be considered whenever safely possible. Microsurgery appears to be very good for the type 1 fistulas or in conjunction with endovascular surgery. Combined therapy is another option when endovascular surgery has failed. I think these are the key points that I saw. I think a careful evaluation by neurovascular board with both an endovascular surgeon and a neurosurgeon. I think there is a trend towards nowadays, like Dr. Babu Welch, who are trained in both, and they may be better judge than just one particular specialty. I think interdisciplinary collaboration and then between neurospinal surgeons and endovascular surgeons should be becoming a standard over time. And of course, you require long-term follow-up. Thank you for your attention.
Thank you, Dr. Rajkumar, for the elaborate discussion on the management of spinal vascular malformation. Your description was very clear and you could understand many doubts which you had cleared. Before I go up to case discussion, Dr. Muthukumar and Dr. Singh, if you have any questions to the speakers.
Yeah, Manas, I have a couple of questions. My first question is to Satish. Satish, a really wonderful presentation.
Thank you.
And your first case, patient with 36 primary gravida, 36 weeks of gestation. I think it was very well managed, but it brought back memories of one of the cases which I had earlier encountered several years back. This was also a primary gravida, 30 weeks of gestation. The scenario was such that she came with severe back pain and her power was normal, upgoing plantars, mild blunting of sensations below D10, sphincters normal, and MRI showed a D7 vertebral hemangioma with extradural extension just about 20% of the canal. So it's a very mild neurological deficit, severe pain, second trimester of pregnancy. That's a very therapeutic dilemma, isn't it? How would you manage such a patient?
If they come only with the pain, there are 2 ways you can look in. If there's no neurological deficit, you have to explain the patient that the pregnancy increases the size of the hemangioma. Usually the hormones which is related to the pregnancy, when with the peak level, it also increases the vascular components. And that's one of the things which patient has to be told. and also should give the reassurance that unless she has the neurological deficit, a kind of a pain therapy can be given for time being. And once she recovers once she delivers, sometime it can regress if there's only pain. If she gets the neurological deficit, then we had to go ahead with the things which we have done. And then, either the alcohol therapy is slightly dangerous in these pregnant women. So the only option which is available is, PMMA, at least you can inject. Percutaneous injection is also known, with the presence, with the present our experience, we know that percutaneous vertebroplasty I can do even in a pregnant woman with a small dose if you put it in the only anterior part. If she's in such a severe pain, which is unbearable, not going with anything else, I will definitely consider with the Dexam, not a GA. We give the Dexam anesthesia, dexamethasone. Then we can do the vertebroplasty in such patients.
My question is, this patient had a mild neurological deficit, signs in mild neurological deficit, and there is an extradural component. So we were reluctant to proceed with PMMA because the extradural component to inject, even if there's an extradural component to inject, that's a little tricky, isn't it? So in this,
it is tricky, but with the high viscosity cement, and if you put the needle far ahead in the vertebral body and make sure you're controlled well, sometime, and especially if you do open surgery, it is very easy. You shrink a bit, keep watching the posterior wall, you will see the perforation in the posterior wall. That's what we normally do in open surgery where we do the laminectomy. We will shrink the hemangioma first to see at least to the side, not in the anterior part, you can't see that, on the side parallel to the pedicle, and then inject. And when you keep watching, if there is any leak of the soft material, you can remove immediately, which will definitely have a enormous good result to the patient. But without laminectomy, it's definitely dangerous.
My second question to you is, you talked about ethanol causing pathological fractures.
Correct.
So I'm sure you are aware of this month's neurosurgery. There's a publication from AIMS where they have reported for a series of 14 patients with pediatric patients where they had injected intralesional absolute alcohol with short segment fixation. And to the best of my knowledge, I think the median follow-up was 3 years. So they didn't have any pathological fractures.
Because they have done a fusion.
Yeah.
If you don't do the fusion, there will be fracture. That's why whenever you use the alcohol, especially if you require a larger amount, better to fuse. If you don't fuse, there will be fracture.
That's the reason why I wanted to emphasize, because that statement that ethanol can cause pathological fracture should be maybe qualified by a statement that when you do that, you should supplement it with
always do it.
I'm very scared when I inject ethanol anywhere in these lesions. It can cause plenty of problems. It can cause really plenty of problems. I'm sure VP also has plenty of questions to you before we move on to the next speaker.
Just one excellent presentation, Satish.
Thank you, sir.
If a patient just has pain, right now, what is your threshold of actually treating such a patient without any neurological deficit?
See, two things. If the patient is a professional like me or you, who has a pain, who wants to get rid of the pain, the best option nowadays available is a radiosurgery. If you don't want to do anything. So, if the patient is, his bearable pain, and I'll definitely follow him up. And if there is no posterior wall involvement, and if it's bearable pain, definitely you can watch. If not, you can definitely do PMMA.
Okay.
Yeah, thank you, Dr. Singh. Shall we go for the case presentation, Dr. Clemens?
Well, we have to ask questions to the other two speakers.
The other people.
So the case, within the case, you can ask, because we have half an hour left and 2 cases.
Okay.
So the cases are on a cavernoma, and can I request Dr. Sachin to present his case? Sachin, you are online.
Yeah, sir, I am there. So I should present first, or Dr. Arun should present first? I can present.
You can decide among you.
Yeah, I'll present. I'll present. No issue. Yeah. So just a minute. Yeah, I'm sharing.
You have a case. Okay.
Is my screen visible?
Yeah,
Yeah.
yes.
Yeah. So good evening. After the brilliant talks, I'm presenting a case of a spinal vascular lesion to be discussed. So this is a 17-year-old female who presented to us with back pain in the mid-back region for last 6 months, a spastic paraparesis for last 3 months, urinary urgency and frequency for last 1 month, and she's bedridden for last 15 days. There is no history of trauma, no history suggestive of tuberculosis. Tuberculosis is quite prevalent in India, so we frequently ask this history, but there is nothing to suggest. On examination, she had a neurological examination. Her tone is increased in both lower limbs. The bulk is normal. Power is, she's quite spastic, and power is just 1/5 bilateral lower limbs. Knee jerk and ankle jerks are all 3+. The plantar is upgoing and abdominal reflexes absent in all quadrants. On sensory examination, there is impairment to all modalities of sensation below D6 level. Local spine examination is unremarkable, no obvious swelling, tenderness, or deformity. So we investigated her, and this is her MRI. There is a lesion involving the D5 vertebral body with an ventral epidural compression. On axial MRI, this is the picture. There is a compression from both sides ventrally, and the vertebral body is involved along with the right side pedicle most likely. These are the typical honeycombing appearance, involvement of the right side pedicle and the entire vertebral body of the D5. So I would like to ask the panelists to start with Dr. Rudrappa. So what are our treatment options in this case? You have an excellent presentation. So a disclosure that I have used some slides of your presentation.
Very good. No problem. You put a disclosure. Good.
Yeah.
See, I think, she has only pain. She has this neurological deficit also.
She has a neurological deficit.
Yeah. So when she has neurological deficit, 17-year-old at D6 level, I would love to do a small laminectomy, shrink whatever it is possible from my side, and then inject the PMMA without a fusion.
Okay. So do you think that just injecting PMMA and without doing a decompression ventrally, because the compression is predominantly ventral epidural rather than from the back. Correct. So will it help in recovery of her neurological deficit?
Definitely yes, because it is very well known, as I told you, with the exothermic reaction, the cement, even if you do not completely fill it, the amount of the blood supply which comes from the periosteum of the vertebral body and from the lateral dorsal recurrent arteries will get clogged because it has to come to the middle of the body, metaphysis, and then it turns down and supplies the whole vertebrae. So all these things will get burnt because of the exothermic reaction, and also some of the filling of the cement. It definitely, the whole of the tissue which is seen in epidural space, if you do the scan at the end of 3 months, it will be gone.
Okay. So Dr. Babu, do you have any opinion on this, or you will agree with this management plan, or you differ?
You have to unmute, Dr. Babu.
Yeah, I'll figure that out one of these days, huh? So, yeah, I tend to agree with that. I mean, you could always, with the neurologic deficit, the decompression is a main issue here. So, but I can't say I would do anything different there.
Can you have the CT scan projected?
Yeah.
Yeah, keep it that way.
Mm-hmm.
So, Dr. Muthukumar?
I'm sure what Satish said is certainly one option, but then I would prefer a short segment fixation in addition to what Satish said, because This patient is almost 17 years old. She is unlikely to have any big growth spurts, so unlikely to have anything like a crankshaft phenomenon, etc. I would be more comfortable combining what Satish said with the short segment fixation.
Yeah, I wanted to, I guess, ask that question. What do you guys think? I mean, if you look at just the height of this vertebral body, is that in itself already representing a fracture? And would that support what Dr. Muthukuma was just saying, that it needs to be supported going forward?
The reason why probably Satish, if I may intervene, if probably Satish wants to do only PMMA, is that PMMA probably itself provides some support, but it might be better because she's a very active young individual with a long lifespan ahead of her. So I think it might be preferable to do a supplementary short segment fixation.
Yeah, in the scan, it's not only the anterior segment involved, because you have involvement of the spine, of the pedicle. So just doing a step PMMA in the vertebral, whether it is enough stabilization. So I'll agree with Dr. Muthukuma that the short segment stabilization will be better in this case rather than just doing a PMMA.
I completely disagree.
I think, I mean,
Okay.
a lot of ability from that as opposed to your
You have
column.
to justify, no, why disagree.
Yeah, the thing is, the beauty of the vertebral hemangioma, especially like this, is, you can fill the cement closer to 6 to 8 cc. When, and complete height can be, because there it is like a pillar. If you see the pillars within the laminar pattern is very well preserved in this patient, and it fills every part of it. And it is in the mid-thoracic level. There's a rib to hold it, and you're just doing a decompression only posteriorly. So with that, if it's not junctional. In a junctional, sure, it is required. If it's not junctional, even the literature says that, it gives a very good result, because it's unlike in the vertebral fracture of the osteoporosis, where you cannot lift, you have to use the balloon or something to lift it and create the vacuum and then fill the cement. Here, it eventually passes through every corner to you.
Dr. Satish, the conventional teaching is that if the posterior vertebral line is disrupted, then the cement augmentation by vertebroplasty can be dangerous. So obviously you told us that with a high viscosity cement, it may be avoided, but for the people, actually not many people manages this quite frequently. So for the newcomers or the young neurosurgeons, do you have a word of caution in such cases? Or
the word of caution is, whenever you do the decompression, please use the microscope, number one. Number two, slowly coagulate the epidural space with continuous irrigation, or if the present day bipolars, which are non-stick technique, slow compressing, electrical current usually shrinks it very well, and it almost becomes a parchment membrane-like, and you will start seeing the sieves in the posterior wall, that where there's a broken part, where the vessel is coming out, the hemangio component coming out, you can clearly see. And then inject the cement. So decompression first, second is the shrinking, see the posterior wall on either side, and then under microscopic vision, you inject the cement. Then you will see if the cement coming out, when it is soft, you can easily take it out, or you can flatten it, so that there will be a layer between the dura and the posterior wall, which will definitely protect it. But you have to use it under the microscope. Don't do macroscopic, because, keep watching the cement, how much it comes out, because once it is solidified, it is impossible to take it out. And it will come like a small blebs, and it will be very solid. You have to drill it, which is not possible when there is a significant leak. So when you inject the cement, inject under microscope.
What approach will you take, Satish?
I do, regular standard transpedicular approach. And I make the path in the pedicle only after shrinking, because otherwise it will start bleeding. So you had to first decompress, shrink as much as possible, and the bleeding will be quite significant when you enter into the pedicle. So, and enter as anterior as possible.
So this will be an open surgery or MIS
open surgery? It is an open surgery.
So
why wouldn't you begin with the pedicle injection and then go open? You could probably decrease the bleeding interventionally.
Yeah, correct. We can do that provided the posterior wall is not breached much. If the posterior wall is breached, then you have to decompress it well, and you have to keep watching that posterior wall. Otherwise, the cement leaks. Taking it out is very difficult. Patient rapidly worsens. By the time you do the cementing to the laminectomy, if you see, for example, the patient which he has put in, even in the lamina, there is hemangioma component. It bleeds a lot. And you will not have a time to take out the cement. By the time you enter the cement, it would have solidified in the epidural space, which is dangerous.
Yeah, you need a hybrid, a use of a hybrid room, where you've got all the angio equipment there. You've got your good fluoroscopy that you can see, but the patient's already positioned and ready for decompression, etc. But it might help with the bleeding. I agree, it's going to bleed a lot. So it might help with the bleeding if you actually have, you already have your trocar there. So, but
I have a technical question, Satish. I'm intrigued by this. How do you do this? Like, you have one person inject and look at the fluoro screen, and then you have another person look through the microscope at the same time? Or can you walk me through this a little bit? I'm curious.
So what I do is, I keep the table as low as possible after the decompression. So I have a biplanar imaging, and I keep it, I use on the single planar. In this case, I don't use the biplanar whenever we are injecting the cement. And I keep the table so low that the microscope at the higher level, focus it so that this, the stellate which passes through the probe, is still under the view. It will not hamper your vision through the microscope. And I ask my assistant to inject on the opposite side, half of the total stellate what you use. Then you can use the microscope to watch on the one side and have a focus. As you said perfectly, two people should be doing. One is injecting, one is watching. And keep the table completely low.
Satish, any deterioration following PMMA injection is not only because of mass effect caused by the bone cement, but also by the exothermic reaction, isn't it? So,
which is a rare. Dura is such a beautiful layer. I have done so many vertebroplasties, and I never seen anybody deteriorating because of the exothermic reaction.
Yeah, Dr. Sachin, can you tell what was done, and then we go to
anybody for alcohol injection?
Obviously, given your recent publication, you would have injected alcohol only.
So I am biased, but this is open forum and an open case. So anybody for alcohol injections you would like to do alcohol, sir?
Alcohol, yes, possible, but in very small aliquots, which very, very, very small, and then wait and see for any systemic reaction. In alcohol, the problem is systemic reaction, which Satish mentioned. I had some bad experience early in my career with absolute alcohol, so this can be done certainly, but one should be much more cautious while using alcohol than PMMA.
Anybody would like to do maybe a posterolateral decompression to remove this ventral epidural compression, maybe by an extracavitary approach or removing the rib or something, in addition to what has been already said, that you stabilize or you put cement to decrease the vascularity. But again, the patient is almost paraplegic and a young patient, so we want her to recover, and the best chance of recovery is by doing a decompression in front of your eyes. So anybody?
That is the reason, Sachin, why I asked this particular question about the approach to Satish, because to reach the ventral surface of the ventral dural surface, I think lateral extracavity should be a good approach. You expose it and then put two screws, one screw above, one screw below, and then start the injection, whether it is with expose through a lateral extracavitary approach the anterior margin of the dural sac. And then if you start injecting either cement or absolute alcohol, then you are reasonably safe.
But in the plan by Dr. Satish, there is no plan of fixation. So it's just putting a cement and so obviously fixation is not in picture till now. So if we are doing a lateral extracavitary, probably we need to fix, because we may have to go bilaterally also, because it's an compression from both sides.
Sachin is not required.
Okay.
Sachin, can you conclude so that that's
Yeah.
what was done so that
So
was
this has been borrowed from Dr. Satish, that the aim is again to shrink, stabilize, avoid complication and prevent recurrence. And the various treatment options, obviously, we have already discussed, Dr. Satish has beautifully described that these endovascular and percutaneous alcohol and all are not that great. Radiation and cyber knife, again, that can be done if it's just a pain and no neurological deficit and a contained lesion. Cement injection, we already discussed. En bloc spondylectomy, no takers for that. And absolute alcohol and decompression plus minus stabilization and cement are two options which have come out of this discussion. So as per Dr. Satish literature review, this is what is the which provides the best thing. Everything is ticked in this posterior decompression, PMMA and fusion. And the close second will be maybe ethanol injection if we are also doing a stabilization. So let's see what we did. So what we did is actually guided by this our original publication from our center by Dr. Sharat Chandra, and absolute alcohol injection, laminectomy and short segment fixation. This initially was as a pilot study, was published in Neurosurgery in 2011. And what is actually done is one level above and below the lesion, we put screws. And then by inserting transpedicularly the Jamshedi needle, we inject alcohol in small aliquots of 0.5 ml gradually, so that instantaneously you can see that the vascularity of the lesion is gone. So initially when you insert the Jamshedi, there is rapid gush of blood, but as you start injecting, and around 3 to 5 ml on each side, a total around 10 to 15 ml in each vertebral hemangioma, we get a good embolization. And as it is known that absolute alcohol can cause pathological fracture, that is why we are supplementing it with a posterior stabilization along with a posterolateral intertransverse fusion. So that pathological fracture has been taken care of. With this alcohol injection, all the epidural component also shrinks over a period of time, and this has been the final picture which happens. You do a laminectomy, so posteriorly you are decompressing, you are stabilizing, you are putting alcohol, and the advantages is again the direct visualization, decompression, instrumented stabilization. So we are relying on one more factor of stabilization, so that there is no fracture and collapse later on. So it is also very cost effective, at least in our setup. That is quite low. And then this has been now almost has been long-term results are also published in 2018. 33 patients, a mean follow-up of almost 4 years, and all patients improved. One patient had a transient neurological deterioration which recovered within 2 months, and he also ultimately recovered, and one intra of hypotension. So it is not, if it is properly done in small aliquots, it is not very dangerous. So we have now almost done 50-60 of these cases over last 10 years, and the results have been really good. So no fractures. no long-term neurological deficit. And this patient is one of our initial patients. He almost 10 years now, no recurrence, completely recovered. And this is her post-op picture. So what you can see is the ventral epidural compression is gone, and there is some sclerosis also in the body after injection. So if you compare this pre-op with the post-op, the ventral epidural compression is gone. And axial images, this is the pre-op one, and the post-op ventrally, it has shrunk. We haven't decompressed it. It has shrunk on its own following injection. Then this is the pre-op CT, which has improved. There is a bone density has definitely gone up. There is some sclerosis. So if we summarize the management of hemangioma, obviously this slides is pretty important, and everyone should have this on their desk. So this PMMA, posterior decompression fusion, is pretty good. And what comes a close second or almost equivalent results as per our experience is ethanol injection with stabilization. So if we are stabilizing, this pathological fracture is ticked. It's not that complicated. We have seen it over the last 10 years now. And there has been no recurrence in our experience. Initial one case had recurred. Only one case out of this 50-60 cases had recurred. But again, when we did a repeat injection, and then she is doing well for last 7-8 years. So obviously, these two options should be always thought of in case of vertebral hemangioma. And thank you for your kind attention. Sir,
Thank you, Sachin, for the beautiful case. And yes.
Yeah, Dr. Satish, if you wish to add on this.
It's good. We are already concluded. Let us not, we'll go to the next case. Thanks, Sachin.
Thank you.
And Dr. Arun, please, can you present your case, please?
Yes, sir. My slide is visible.
Yeah, yes.
So I'll go quick. As a surgeon, we are dealing mainly with the type 1 AVF. So I'll go with a few cases, and then I'll open the discussion simultaneously. So the first case is 48-year-old male. He was farmer by occupation. He was having background spastic paraparesis. Then while working in the field, he developed a sudden onset flaccid weakness. And then after a few days, when he recovered, we have found that his weakness were in both the lower limb, and the weakness were symmetrical, and upper motor neuron type of weakness was there. And when we have scaled on the Aminoff log, we have found his gait was severely compromised. That was 5, and his bladder and bowel control was gone. So this was his radiology, where it was classically, as Dr. Rajkumar has already shown, a beautiful radiological picture. In T2 weighted images, it was showing card edema with a lot of vascular channels, flow voids. And in axial scan, you'll see a polka dot kind of things in the peri-spinal and the foraminal area. So this was the radiological picture. And when we did the DSA, the intercostal run was done, and we have found this Fistulas connection. So this is a straightforward case. I'll raise the controversy at the end of my talk. So this is the first case where this was a type 1 spinal dural AVF. And one more thing I want to add from our center, that most of the time we are getting these cases because of the cost issues as well. So this case, and then this case, this is a very interesting case where the interventionist has found a feeder from the radicular artery, which was supplying the dominant PSA. So dominant PSA from the feeder is one clinical situation where this controversy comes, whether we should go for the glue embolization or we should go for the surgery. And then the another situation is the kind of when ASA is arising from the getting augmented from the Fistulas feeder. So I would like to bring these three scenarios in front of the panelists, and Dr. Babu and Dr. Rajkumar, that these kind of situation, one is straightforward when we are open for both surgery as well as endovascular procedure. Second situation, as I shown, the dominant PSA is getting supply from the radicular artery. And third situation where the ASA is getting supply and support from the feeder artery.
It's 9 o'clock.
Hello, am I audible?
Yeah.
So first I would like to put
one person and they'll answer you.
Yeah. So Dr. Rajkumar, sir.
Yeah, I would like to take opinion from Dr. Babu. He is our guest. Dr. Babu, these are interesting cases. So obviously, I would like to know your opinion.
Yeah, I enjoyed your talk. Your talk was perfect, and I think it kind of addressed the trends, but plus minus whether or not they're good. I think we're at a point right now where we have good endovascular and refined surgical options, and so I think these three cases are good looks at those. I think a point to bring up is you have a lot better understanding of the vascular anatomy in the endovascular side. Right. So if you're really coming close to, it's very hard to know exactly which vessel you're at, unless you're in a hybrid area or you're doing the angiogram looking and doing the angiogram looking back and forth, because the spinal cord a lot of times is in the way. So for your, to me, what's the most direct way of getting to the fistula? The first one you showed, I agree. I think we get really good results. When we first started talking about this and publishing it, we were 72, 73%. We would say it was a good chance of being able to do this. And that was well before Onyx and other things. Now, 90% of the time, more than that, you can take patients and cure them endovascularly. So if there's an option there, but if you get to a point where just a little bit of, and I will talk in terms of Onyx more than glue. If you're worried about a little bit of reflux, or you're not sure where it's going to go, surgery is a lot faster, a lot of times, and the radiation is less. So I think one of the things we have to think about is how much radiation. And you sit in a large metropolitan area, and every once in a while you're going to get somebody the radiologist who doesn't have any backup tried, and next thing you look up and they've got 7,000, 8,000 milligray of trying, and now you have to make an incision on their back. And that doesn't tend to heal very well when you're trying to have someone. So, typically for me, I think, if there is, my typical rule is if I'm going to spend, more than an hour getting to the place that I need to embolize, then I probably should have just taken them to surgery anyway. I have a low threshold to take them. And there are times where where there are multiple components and we've taken care of one endovascularly, but we bring them back the second time with the catheter in, we turn them over, we've got them on their stomach while they're ready for surgery, and then doing that. So your first case, I would probably lean towards the endovascular. I think when you're having, if you have supply, and this would be one where you might not get exactly where you might not be able to push all the way into the vein. Right. And when you have to push all the way, if you don't push all the way into the vein, it's coming back. It's just a matter of time. And so at that one, you push it, you give it a shot. If you don't get into the vein, then you bring them back for their follow-up with the plan to go ahead and take care of it surgically. That would be the thing. But sometimes you see these very diffuse ones, especially when you see that much flow to the vertebral body. But when you have, I've had a few that it is the artery of Adankowitz that is supplying the fistula. And again, I would typically opt for endovascular at that point because I know exactly where I'm going. And those I've gone through the artery of Adankowitz with some vasodilators. So you vasodilate, make sure you don't have spasm, take the catheter through all the way to the end. And typically a lot of them have been more conus lesions. So you go through there and you can take that down. The scary part about those though, is all of a sudden the flow in the artery of Adankowitz goes down. And so you slow flow in the artery and you're worried, oh, what did I just do? But it's going to, because it was a fistula before, right? So it's going to slow down. You make sure you watch your pressures, make sure the vasodilators are used, and you can get good results from that. But I think if I don't want to go too long, I want to give you also a chance to comment, but that's kind of my general idea. The other, so that posterior spinal one, it's not that big an artery. So again, would probably be, yeah, that would probably be surgical, with using using the in an area where you can either use a biplane, or we have a pheno arm here, which you can use to actually move around and see exactly where you're going, and be very careful with that. But
yeah, actually this was a dominant PSA, and it was arising from the feeder. So actually the first case, which was the straightforward, there was a cost issue, so we have gone for the surgery and patient did well. But in this case, actually it was referred from the interventionist, as PSA was arising from very close to the feeder. But this case is very interesting, as ASA was getting augmented from the feeder, which was supplying the fistula. So what they have helped us, they have put a microcoil in the radiculomuscular artery, so that this can be identified during the surgery. It was very well appreciated during the surgery on fluoro, and we were able to achieve a good job. So this is what we have done in this case, and it was very interesting to note that this has really made the surgery very easy, and localizing this fistula site was very easy. So this case was operated where the augmentation of ASA was there with the from the feeder, but PSA, where the PSA was taking supply from the feeder, that was also operated from surgical side, and patient did very well. His Aminoff log score has also improved drastically.
yeah, we call that leaving breadcrumbs. So
Yeah.
So at least you can do that. So yeah, that's good.
Yeah, in this case, actually, when they were preparing for the embolization, then suddenly they realized probably they have, during the diagnostic DSA, they have left this augmented ASA. So they did the angio above and below. Then they have found, yeah, actually it was augmenting ASA. So this case further they have stopped, and it was referred to us, and ultimately we have operated this case. So as Chandrasekhar sir rightly said, that we should be very careful about the type 1 SDAVF, where we should be seeing on few important angiographical detail, like whether the ASA is getting augmented from the feeder, PSA is getting augmented from the feeder or not. And last case, this was a case of sacral AVF, and this going surgically to this low is actually very difficult. So I would like to ask again the moderator and Rajkumar sir and Babu sir, Dr. Babu, that what's your take on these kind of low lying fistulous connection, which is actually lying at the level of S3, S4 somewhere, very, very low, and going surgically is really difficult.
Right. You want me to run with that one, or you want to comment on that?
Please go ahead, Dr. Babu. You have more experience in endovascular.
So I obviously that when the surgical approach becomes more difficult, you're going to lean more towards the endovascular. But it's not that you can't get there. It's just I think I would probably have a little bit more of an endovascular route. It's very, very tortuous to get there, and it doesn't look like that is your microcatheter about as far as it's probably going to go. So if we wanted to really be tricky about this, if there was any kind of potential transvenous component to this, or a transvenous option, we're doing that a lot more in the fistula, in the cervicomedullary junction, in the head, spine. I can't say that I remember doing that, but I wonder where that venous drainage is, because that looks pretty straight. That would be another just thinking outside the box option. But if I had to guess, I'm guessing you ended up operating on this too.
Yeah, even we have gone for selective lateral sacral catheterization, and ultimately it was embolized, and it's all gone, this fistula, and patient did very well.
Good.
So
that far.
These were the cases from my basket. The only thing I would like to conclude from my side, as a with 15, 16 odd cases experiences, that I always keep differential diagnosis. In differential diagnosis of cardiedema, I always include SDAVF, because sometimes you get confused with the intramedullary tumor and then you go ahead with the biopsy intention and you actually deteriorate the patient. And this what I have learned over last 7-8 years, that always read the spinal angio with intervention colleague, because we are good in reading the cranial angiogram, but obviously this reading spinal angiogram is a different ballgame. And actually, I actually suggest all the young neurosurgeons to not get trapped in the nomenclature. Yeah, you should be knowing all the types, but getting trapped is actually inhibits you to go for the surgical options. So just talk to your intervention colleague, understand what you can do as a surgeon in that very case and do it, and always call the interventionist to the OR. Because once interventionist is there in the OT, now he will definitely help you in finding out, because these fistulas connection is not like one-to-one arteriovenous connection. They are sieve-like. So it's always better to call them and just try to localize the vein which is actually getting engorged, and try to coagulate or cut that vein as close as possible to the fistula. And never hesitate in going for check spinal angio if you are having any doubt during the surgery our patient is not improving. Because in one case we have found that we have actually done the surgery at one level above, while it was supposed to do a level down. So never hesitate, because immediately after the check angio we have gone again and we have done the surgery successfully and patient improved significantly. And you, as far as possible, utilize your all the possible gadgets like Doppler, Introp, ICG, fluoro, and monitors. So that's what I have learned over the year. And if moderator and Dr. Babu, Dr. Rajkumar would like to add anything to that.
Dr. Babu, I'd like to ask, what is your protocol for getting a post-treatment DSA done, spinal angio? Do you do it in all cases? At what time? And what about the non-responders?
Yeah, I usually kind of as a standard, I do 3 months out for all of them, just to make sure that we're seeing everything. Obviously, we follow clinically. Essentially, I spoke about this at a national meeting one time, and I asked the same question. And I asked the question as, how many of you do long-term follow-ups? And a very small minority in the room actually did follow-ups in that, and it was a well-packed meeting. So I got the impression from that maybe that's not the norm, that maybe a lot of people were following patients clinically. I don't necessarily agree with that. I think I'd rather catch them before they go back down their route of slow deterioration again. And then, for the I guess a non-responder would be not treated, and that would be, if there's recurrence, then we have to kind of look at what our options are at that point. I think to me, the AVMs and the fistula are such fluid lesions, you just have to kind of roll with the punches, is the way I think about it, and understand the anatomy. I agree that it's easy to put these in baskets, but it's actually hard to put them in baskets. I mean, we can get them close to and lump, but I'm more of a splitter than a lumper. So, but
can I have a question to Dr. Babu, please? Hello.
Yeah, please.
This is a very basic question, maybe even naive. How do you select based on your MR? If MR shows a suspected arteriovenous shunt, how do you choose which level to catheterize for diagnostic purposes? Because do you just do an aortic run, or do you selectively choose the level based on the MR? Because if you base it on MR, it is possible that you might miss something above or below, isn't it?
Yeah, that's actually a great question. And we've kind of evolved here over the years. In the U.S., this is a very expensive study, right? I mean, if you're going to do an angiogram, you're basically doing, all the way down to make sure that you catch everything. And we initially, when we would do that, we would do all levels, make sure we saw everything. And you got to the point where the X-ray and the amount of dye you've given, you really couldn't plan on doing a angiogram and a treatment at the same time. So you'd have them, you cool them off, and you bring them back. Now we have pretty specific MRA protocols, so 4D MRA we call it. So we can do an MRA and focus. It's a dynamic study. And then based on that dynamic study, we can really limit how much radiation and how much dye. So a guy I have tomorrow actually is someone that, you know, I can now have a conversation with them about, we will come in further, I understand your fistula, and then we may be able to treat you at the same time because of what we've talked about. You know, it's likely to be an endovascular attempt first, right? But now we can diagnose on MRA, angiogram to refine, and then potentially treat during the same session, which is a little bit safer for the patient. So that's a natural question, I think, and we've evolved here. I would say we probably started using the MRA more routinely 3-4 years ago. So before that, it was a lot of spinal angiograms, and we still have a lot of transverse myelitis. Someone showed a case on that here. A transverse myelitis been treated. The guy that I'm treating tomorrow was an MS patient that, you know, was being treated for MS. You know, MS in a 46-year-old male, you got to think you might be dealing with something different, right? But he had the cervical course of 2 years of progression before anyone did an angiogram on him, and they did the MRA and found a really good lesion with feeding right at I think it was T6. So,
I was looking into the literature, Dr. Babu, and I was trying to see if CT angiogram were to make any sense or any difference. There's not much literature on that. Your thoughts on that, please.
you know, I think we just haven't, because you don't get the same spinal cord information. So I think we probably lean more towards the MR because we can see edema. We can kind of focus on the level at that point. I think if you knew, you know, if that's what you had and you knew where you were going and you just wanted the vascular information, I think that, you know, a 320 slice scan or something that's going to give you a good range to scan over is reasonable. I know Clemens is on. I don't know what you all's protocols is on the management of or the evaluation, but MRA has gotten good enough for us. I think we just use it and we get kind of all in one fell swoop, and they don't take that long. When we first started using them, we would always do our spinal angiogram to validate it. We would do the MRA that morning and then bring them to spinal to see if we saw the same thing. So, and we were getting pretty good at them, so we just defaulted to that.
One challenge with CTAs is that they're difficult to gate to pulsation artifacts, which you can do with MRI protocols in the spine, which really makes a huge difference. As you know, a lot of things we look at in the spinal cord and say like, well, that's got to be a pulsation artifacts, right? There are actually techniques to overcome that, but that doesn't really work for the CTA, just by, you know, the way it's done. Right. And I think to address the other question that was just sort of touched upon, I totally agree with Babu. You know, I think from the angiographic perspective, it has to be a positive identification of that feeding vessel. If you can't find it at that presumed level that the MRI might indicate that it is there, then you got to keep going, right? I mean, we all have seen these textbook examples where you have pathology like venous congestions or, you know, at a given level, but the feeder is somewhere else, like much higher or something like that. And unless you truly find that connection, you have to keep going. And yes, you sometimes have cases where you essentially do a diagnostic study that incorporates the entire spinal vasculature until you find that connection. Mm-hmm. So you got to be happy basically with that. What you found supports the theory of what's going on, right? You can't just walk away from that saying, it's got to be there, but I can't see it. That probably is, that's not helpful in the end.
Yeah, that just means they're getting another somewhere else.
Yeah, exactly, right.
One of the cases which Rajkumar showed was a patient who had a cranial SAH who was found to have a, if I remember correctly, a cervical AV fistula. Am I right, Rajkumar?
Yeah, and we have had the patients like that who come with subarachnoid hemorrhage, blood in the fourth ventricle, third ventricle, and then, you know, you evaluate, the brain is normal, the patient has to have bleed somewhere else. And many times you have said that, you know, it is a cranial angionegative patient, subarachnoid, to be followed up. But actually, if you were to look at the MRI of the whole spine, you will start seeing some flow void somewhere or some T2 weighted change. I think you have to chase it. Chasing is a very important thing. I still remember when I was a resident some 30 odd years ago, this particular case report by Sethi Rangachari. I think if seniors will remember this particular case, patient has had multiple subarachnoid hemorrhages, the brain angios were done, it's all normal, CT scans were showing subarachnoid hemorrhage, but he chased the patient and he had an anterior spinal artery aneurysm which was clipped. I mean, that was an eye-opener for us to look at all those patients who were negative angios for the brain, look for the spinal abnormality, and you will be surprised that you will find some patients who have had spinal DAVFs or AVMs. I think it's easy to give up. It's very hard to chase.
Yeah.
I think one of the reasons.
The wonderful cases you showed, luckily my center is one of the centers where we do both endovascular. My partner is a very good endovascular surgeon. And whenever we do this kind, both of us participate, because in case if he's too tired with multiple and identification of thing, I take over. And with the modern technology of, you do exactly like a cerebral aneurysm, especially both the AVM and dural fistulas, especially when there is a supplementary thing which is happening to interspinal artery. We use the micro clips first, to see exactly like an aneurysm, how we used to do once upon a time. And even now we do temporary clips and see whether the cord will have anything. And with the use of the intraoperative monitoring and ICG and a micro clips, temporary clips, a lot of things can be taken care of. I think it is a combination of the intervention surgeon and the neurosurgeon is already in the intervention, makes enormous difference to these patients. Sometimes it is a very tedious finding out these things, but very important in the first shot, make sure you will get the good result. Otherwise, it will become very, very complicated to the patient.
In a patient with an intracranial bleed, if you do a posterior circulation run, I mean, I'm given to understand that it is possible to miss these cervical AV fistulas if you inject only one vertebral artery and look for the reflex, and if you are satisfied there is sufficient reflex in the contralateral vertebral and pica. But in such patients, if you inject on both the vertebrals, it is possible to pick up these cervical dural AV fistulas. Am I right, Dr. Babu?
Historically, the workup of angiographic negative subarachnoid hemorrhage included a cervical MRI for that reason, right? I think I think we here maybe have fallen off that a little bit, but I do make sure that when I'm doing a vertebral injection for those patients that we're seeing a lateral which shows us this, right, and an AP which shows us this. I think if you do bilateral verts that way, then you'll usually catch a cervical medullary lesion that might give you that subarachnoid hemorrhage. But if you stick to the MRIs, more often than not, you're going to catch it. So because we're doing this, I think we've seen more of it, which is why we've gotten away from the MRI. But if you're not doing bilateral verts, at least get an MR that includes a cervical MR, and I think you'll catch it. So.
And I think the few series that show, that whatever you tack on to your workup for those, you will always find an additional % or 2 of problems. So in other words, the first angiogram gets you to, something like 85, 90% of conclusive evidence. The next angiogram to maybe 96 or so. The third angiogram to 99. The MRI gets you another % or so. So I think it's a little bit of a question of how far do you want to take this, right? And that's where a little bit of judgment also comes into play. If you have a good alternative explanation, like the patient who has that typical presentation because they were weightlifting or bearing down on the toilet or something like that, versus that patient where that doesn't really apply and they have a lot of blood, and they maybe have some blood that's lower down or something like that, right? So I think there's a little bit of judgment still involved. We, for that matter, still do the MRI on every patient. We feel better that way because it doesn't really detract that much. They're here for several days anyway in the hospital, so you might as well just add that to the workup.
Yeah.
One question for Dr. Babu regarding the spinal cavernomas. With the ones which have met a significant need, what would be your timing for surgery? Would you prefer to wait till the edema settles down? Or would you want to do them relatively early while the hematoma gives you a good name? to take
Yeah,
that?
hematoma, right? If I think if there's a hematoma cavity, I would use it. If there's more edema than hematoma, then I probably would give them a good 4 weeks or so. Would be kind of my lean on that. But if that one, like the one I showed at the beginning, that was a larger hematoma that we could go in and present it. You can at least decompress it, right? Do you need to go in and get the entire cavernoma out? If it's there, sure. But if you're decompressing the hematoma, then you can return for the cavernoma resection once it's released a little bit. Then, but edema versus hematoma, it's kind of my ratio in terms of time.
Another question to Dr. Babu is that in a cavernoma patient which is incidentally discovered, or it is a part of a multiple cavernoma workup, if the patient is sort of asymptomatic, will your approach for intervention or threshold for intervention be different between a child and an adult? Or will the size make a difference?
If they're asymptomatic, it's the position of it, right? And I think that's where the controversy really, if we want to create one out of this, that's the one. If you've got a deep cavernoma in a child, you just have that's asymptomatic. You just have to talk to the family and say, we'll stay in touch, and this is probably going to present a problem long term, but at least I'm going to make them worse. Unless I've got some perfect midline myelotomy approach to it. But and I would probably take the same. I've got a couple of people now that they just didn't like the fact that we were following them and they were asymptomatic, and then they went someplace else. I think that's the right thing to do. So, but really, you get to the point. We do this with the intracranial cavernomas too. You get to the point where they're educated enough to come back, and you trust them, and then I may let them go for a little bit. But it's usually not. It's interesting. It takes them 3-4 years of coming back and forth to kind of understand this numb finger was not my cavernoma, right? That was because you slept on it, right? So, but talking the patients through, I think, is the important thing. When you have an asymptomatic deep cavernoma, I think I'm not rushing after it. So
the hemorrhage and re-hemorrhage rate, is it different between children and adults?
I don't know that. I think I would probably put it more in a familial pattern versus non, but I don't know a difference in children and adults. All the literature will say that, 30s to 40s is when they start becoming symptomatic. But if I look back, I'd make my number a little bit lower in terms of my experience with it. Probably in the 20s to 40s is when I'd see patients. But I think unless familial, I don't know that there's that much difference. That's my guess.
So intracranial cavernomas have been associated with prior radiation. Do we have anything similar in the spinal cavernomas?
It's a good question. I think we tend to radiate spine less, and with lower doses. So maybe, but I can't say that I've ever had a associated cavernoma. I have had a few for long-term AVMs and things like that. I've seen them in tumors, but I don't think I've ever seen a spinal one that I could trace back to a radiation exposure. But it's good question.
We are already 25 minutes past 9. So if there are no important questions, can we conclude, sir? Dr. Muthukumar and Dr. Singh?
Sure.
Sure. It's been very interesting, the whole discussion. Presentations have been superb.
All the 4 webinars, this was the best webinar. We had a lot of discussion, and then still people want to go ahead. Every time Dr. Clemens will tell getting to go close, but this time he didn't send me a message. He still wants to continue the discussion. I'd like to thank our overseas guests, Dr. Clemens and Dr. Babu, for being there all the time to collaborate in our meetings. And I hope in all years to come, we'll be collaborating together. I'd like to thank panelists, Dr. Singh and Dr. Muthukumar, who had lots of questions. I know they have more questions, but we don't have time. And sorry for interrupting. And I'd like to thank Dr. Satish, Dr. Babu, Dr. Rajkumar for preparing and giving a very lucid lecture. And at least I learned a lot of things from today's lecture, how to manage hemangiomas. And it's supported by good discussion very good cases by Dr. Sachin and Dr. Srivastav to bring about the points of discussion and points of controversy. With this, a few words, I'd like to conclude, but I'll not forget to thank our large sponsors, Mr. Jaru, and supported by Mr. Birender from INTA, who have been always all the time helpful in doing this academic webinars, and they have